Christopher, oh, there he is. Myself, Raj Gandhi. Okay, Carla? Not here. Elma Lopez. Okay. Lisa Price.
Here.
Alex Ramos. Here. Christy Reeves.
Present.
Kathy Rogers.
Here.
Lori Benson. Bob Winchell. Oh, okay. So Miss Klein sends her apologies, but she is moving her new hospital in, so we will push forward in her stead. We will start off with the items on the agenda. The first item on the agenda is the review of the current DSHS, EMS, and trauma system rules. Do we have a proponent for that?
For the trauma rule revision, we are currently working on that. We've had one stakeholder meeting. We have a second coming up on September 14th. That is going to be located at the K100 Auditorium at the main DSHS campus. We will have the last 10 pages to go through of the rule that we did not get through, so we will be reviewing the last 10 pages, and I will have those posted up about 2 weeks prior to September 14th.
And for the RAC and TSA rule, we are scheduled tentatively right now to review those September 21st or the 23rd. Location to be decided. We're currently searching for a spot, and that's 157, 122, 123, and 2 definitions in 157.2.
Okay. Now, will that complete that rule review?
That will not. We had our first stakeholder meeting in July. I anticipate probably at least 3 or 4 more. There's some controversial stuff in there, so we will be going over that in, I think, in the next few months. I would like to have a draft that folks could see at GTAC by November. It's not a final draft, though.
Okay.
Yep.
Very good. Okay. Next on the agenda, the Trauma Strategic Plan revision. As many of you know, for the last year, we've been working on the update of the 2002 Texas Trauma Strategic Plan. We've been working on that with the committee's involvement for the last year. At the end of July, we had a focused council meeting, an open meeting, and went over that document basically word by word. Made about 250 revisions to that document, and that document will actually be presented tomorrow to the GTAC Council for the council to review. Chris Drucker, is Chris here, or anybody for the data?
So I can give the update for the Trauma Systems Registry Work Group meeting, which was yesterday. Just a side note, Chris Drucker, for those who don't know, has taken a position in Utah. So he is no longer with the Texas EMS Trauma Registry. Folks there, their consistent message has been that it's business as usual. They are fully staffed otherwise, so customer service is continuing to improve. It's great right now. So it's pretty much business as usual, and that position has been posted, I believe, for a couple of weeks now for Chris. And according to Heidi Bohez, the acting manager and current director over there, they've had, I think, 20 plus applicants. I may be wrong. So
okay, so not that Chris wasn't important, but we can still do business as usual.
Absolutely, yeah. And that's
Okay.
been that consistent message there.
Okay.
And I will give the work group update here. So 3 key points from yesterday's meeting. The trauma registry is now NEMSIS 3.3.4 certified, and they expect testing and implementation, the early phases of that this fall. I think a few RACs have stepped up to volunteer to submit data at the NEMSIS 3.3.4 level. one of the requests last month from the work group was that legacy data submission be extended for one more year. So that's been done. So the previous acceptance date was December 31st, 2015. It is now December 31st, 2016. So they will be accepting both the legacy data and NEMSIS data in the interim. So that will give stakeholders, EMS folks, and their billing folks time to make that switch, which is good news. And then,
Do you foresee any problems in any of the RACs or agencies making the switch to the new NEMSIS?
I think that extra year will give us time to work through any problems that arise. I know that the trauma registry folks have been working hard with webinars and educational opportunities to address any issues that might be coming up. So yes, I'm sure there may be, but we are working hard to address those as they arise. So.
Okay.
And then that last point is the registry and the working group are continue to collaborate on the EMS and hospital data sharing point. So there's been frequent communication back and forth about potential barriers to data sharing and so forth there. So
Okay.
it's been good work.
Okay. Any questions from the committee for Colin?
Thank you.
The next report is the medical directors work group. The medical directors work group basically has been sort of on a hiatus because all of the work product has been put into the strategic plan. As we present the strategic plan tomorrow, assuming it's revised or it's accepted by the council, some of the first elements that the medical directors work group will pursue more in earnest will be guidelines, basically reference guidelines, particularly for low-hanging fruit, such as elderly and traumatic brain injury. Item number 5 on the agenda, Trauma Systems Committee Mid-Level Provider Work Group. Is Kelly here? No, Kelly.
I don't think Kelly's here. Last time she'd given me an update, but I haven't heard anything.
Okay. The next item on the agenda is the TQIP initiative, the state TQIP initiative. Is Matt Davis here, or anybody that can speak for the Texas TQIP initiative? Come on up, Brenda.
TTAF, the board approved TTAF to become the supporter of the Texas TQIP project. We had a conference call with Matt Davis and Jory on Monday, worked out a few of our questions regarding the role and the activity of the project, and I believe Dinah has signed the contract with Texas TQIP now this week, and we'll get that all taken care of. And so my understanding is the first data that we will be receiving will be in March of 2016. Okay?
Who will be submitting data?
The hospitals that are already part of TQIP
Okay.
in Texas, and I believe he told me there were 14 facilities, and they're encouraging others to participate, and they will eventually try to move towards bringing the level 3s in as well.
Okay.
I think there's only 2 level 3s right now. The rest are 1s and 2s.
Okay.
Okay?
All right. Thank you, Brenda. We already, Trauma Registrar's Development Work Group, we already talked about that, Colin, yes? Yes, Colin?
Yes.
Okay. Inclusion of the standalone EDs in the trauma system. We have a proponent. I know that the medical directors are actually working on this, actually, specifically. Is there anybody that has any information on that from the system perspective? Okay. I'm sure that we will get plenty of information at the council tomorrow on that.
And just at some point in time, the state will be coming out with a statement about freestandings. We just didn't get it done quite yet for this meeting, but we will be doing that.
This will be in addition to I guess there's been a council chair charge to actually develop a work group about freestandings. Will this be an additional effort?
Yes.
Okay. I'm sorry, we can't hear you. The work group for the freestanding EDs will be at 1600 today? Yes. Okay. Okay.
Mr. Chair, just a point of clarification, item number 7 there, it's not the same report, so Irene Lopez, we haven't heard from her yet, so.
Okay.
The only thing to add to what Colin already said is we just had some more discussions on adding a little bit more of a process in the state registry for the validation of the data, just to make sure it's quality and validated before it even gets sent to the state on the hospital's end.
Okay. What's the process going to be to do that?
I sent them a print screen of the submission frequency report that we have to do to send to NTDB and TQIP, which is an internal report to go through and validate each data point that the appropriate responses are being entered into them. Then that way we can verify, see whatever we find that needs to be corrected before we actually send it in.
Okay.
So it just improves the quality of the data.
Okay.
And they were a little concerned about too many null values being sent in, which would then not allow us to really know anything about the patients that are going in.
Okay.
So
Which they are you referring to?
the state and the Texas Registry.
Okay.
The epidemiologist.
Okay. All right. Very good.
So.
All right. Thank you.
Irene, sorry. I know that Chris was working on this and he had a timeline. And I know I've been asking the last couple of meetings, do we have a timeline as to when this is going to get completed? What Irene just spoke about? The same process that we follow for NTDB, the frequency report and all those things, to actually have it in place for the state trauma registry?
They haven't really said. I just sent them this print screen yesterday that they're going to evaluate it and see if it's going to be possible for them to do it.
We're actually being recorded and viewed remotely, so.
I just sent in the print screen, so the state is going to review it and see whether or not their software vendor can actually reproduce that same process within the software. So it's just in an evaluation phase right now.
That's good. It's just a suggestion, since Chris has been working on this, that you guys go back to the paper trail and see where you guys can pick up from there. And I think that's a great template to go based off, because that's already made, and that's the point that we made when we started talking about this. Correct.
We had multiple different lists of stuff we asked that they do, and I think it kind of fell through the cracks. So they're going to kind of go back and circle through and reevaluate that stuff.
Great. Thank you.
Okay.
Dr.
Moving
Easter?
into,
Dr. Easters?
was there a question or comment?
I have a, back on the strategic plan revisions, are the revisions located on a website somewhere that can be viewed, whatever's being presented to GTAC tomorrow?
The revisions up to July are on the GTAC site, but the revisions after the council met in July, actually, they are not on the site.
And the council, like the big council met and did the rest
Yeah.
of the revisions?
Yes.
Not this group, right?
This group had input.
Okay.
The trauma, all committees had input into the strategic plan.
Okay.
Most of the corrections and amendments made at the July meeting, most of them were formatting as opposed to substance.
Okay.
So all the substance, everybody those are actually in the document that's on the GTAC site.
Okay.
Moving on to the committee member stakeholder reports. Region 6, nothing from the council other than what we've already spoken of. Any other
Mr.
comments
Chair,
from the council?
excuse me, I've had a request that you speak into the microphone, please. Thank you.
So Region 6, ACS, COT, nothing to report. There's still interest in doing from the college's perspective in doing the regional system assessment, but again, that'll be predicated upon funding. Texas Trauma Coordinators Forum, Courtney Edwards. I'm sorry? She's moving to hospital. She's not here. Oh, she's moved. Okay. Anybody else that can talk about TTCF? This is going to be
Pretty straightforward meeting.
a pretty short meeting.
It's pretty straightforward. Yeah.
Pretty straightforward.
Yeah.
All right. Level 4 trauma centers. Anybody? Ms. Klein is obviously also moving a hospital. All right. We'll move on to level 3 trauma centers. Kathy Rogers or Lisa Price?
I don't have anything.
I don't have anything.
No issues? Okay. Level 2, Lori?
The biggest thing we're still working through is the Orange Book with regards to things like how we're going to track neurosurgical response times, orthopedic response times, just sharing information. We have a level 1-2 committee that meets in the Texas Trauma Coordinators Forum. Terry Valentino's leading that. And basically, we had over 30 representatives at our meeting on Tuesday morning, and a lot of us are just kind of going through frequently asked questions, sharing guidelines with one another. If somebody's already created something, how are you going to do this? How do you interpret this kind of thing? And had really good discussion, and we're going to continue to do those things.
Okay. Level 1 trauma centers. Raj?
About 3 weeks ago, excuse me, the Dallas Morning News has published an article in which the volume at Parkland had been decreasing substantially, secondary to the increase in level trauma centers around the area. And one of the items that came up from that was, again, the whole idea of certificate of need. While this is not a certificate of need state, nor will I think it ever will be a certificate of need state, I think one of the important points of the Texas TQIP will be to look at the quality of the programs, and hopefully those programs that do not meet the TQIP standards will have some repercussions by the state. That is, that they would be de-designated. It's not a good idea for patients to be taken care of at a non-quality program. So I think that's one of the places that we need to go.
So how do you see that? How do you foresee that working logistically?
Well, one would be, the first item would be participation of the centers into the TQIP. I think that would be a mandatory item for being a designated facility, just as it is now that you participate in the state registry. So that would be one of the items that would need to be mandatory. The second item would be...
For designation at which level?
All levels.
Okay.
Because right now 1 and 2 will participate.
Right.
3s is hoped that they will participate. I think it needs to be mandatory that they participate. And then 4s would be the last.
Okay. Anything else, Dr. Gandhi?
No, Dr. Monet, again, out of Parkland, had published how both training of residents as well as training of staff suffers when volumes decrease rapidly. We have not seen that at our institution, but certainly his volume is much higher than ours.
Okay. Moving on, pediatric trauma centers. Lori is not here. Is there anybody else that can? Okay.
Yesterday, the Children's Hospital Association of Texas fired the trauma group back up, and we plan to continue to meet now monthly because we all have realized that no one's getting any kind of trauma team activation funds reimbursement by Medicaid in Texas. They refuse to pay, so we're going to try to figure out how to address that with them. And help me.
We're looking at the trauma add-on. That's the other big piece.
Yeah, that trauma add-on dollars are not, pediatric trauma centers are not eligible for that. And you told me one other thing.
The YMCA has reached out to Chad about drowning prevention, and if you have a drowning prevention program at your facility, you're to send that information to Lori Benson. She's collecting all of that so that we can make an educated decision about what that might look like.
Everybody hear that? If you have a
Actually,
drowning,
okay,
if you have a drowning prevention program at your hospital, please send that information to Lori Benson, because the YMCA has reached out to Chat looking to develop an injury prevention program for drowning, and they're trying to see what the impact of drowning is statewide. We all have our own anecdotal stories about drowning. Drowning's gone crazy in Tarrant County. It's just off the wall. So if you're having problems and you have new programs or programs in existence, send that information to Lori, and she'll share that with the Children's Hospital Association.
Okay. All right, thank you very much. Moving on in the agenda, Texas EMS Trauma Acute Care Foundation. Lisa?
The Trauma Division is working on a couple of things right now. A resource document for burn care has been under development for quite a while. I think right now it's in the hands of a physician for review, and once that is complete, we'll be able to present that. And then we're also working on some educational support modules that we're hoping to be able to develop into webinars in the future. Brenda, would you like to add
Is there any
anything?
other comment from Brenda or Donna in the back? Nope. Other issues to deal with today? All right, EMS, Alex.
Just following on NEMSIS 3, Texas becoming certified. The other thing to that Joe talked about was that Texas will become the 6th state in the country that will be able to correlate EMS patients with trauma patients once they get to the hospital. So congratulations to the EMS people and NEMSIS Trauma Registry for achieving that. The other thing is that he mentioned that the EMS waiver affidavit not to submit information to the State Trauma Registry will end effective January 1st, 2016. So everyone would be having to submit their runs. Otherwise, that's going to have an effect on their licensure requirements.
Just one note to add there, it'll also have an effect potentially on their RAC funding too. So,
I'm sorry, what will have an effect on their RAC funding?
the fact that if they aren't able to submit
Their data
affidavits,
submissions.
if they don't submit their data within 90 days, that time frame, it could potentially affect RAC funding
Okay.
and the RAC formula.
All right. All right. Trauma Center Administrators. That's Ms. Klein on the agenda. Anybody have a comment about for Trauma Center Administrators? THA. Any comment for THA? Okay. Emergency Nurse Association.
That's me. I'm Sally Snow. One of the things that Jory had always asked me to report on was the number of TNCC courses scheduled in the state of Texas, and so I have that information for the rest of the year. Remaining in August, there are 12 provider courses scheduled. 6 of those are full. 3 instructor courses, 2 of those are full. For the month of September, there are 30 provider courses scheduled. 11 are already marked as full. 4 instructor courses, 2 are marked as full. October, there are 33 provider courses. 11 of those are full. There are no instructor courses scheduled for October. In November, there are 14 provider courses. 7 are marked full. 1 instructor course, it is also marked as full. In December, there are 14 courses scheduled. 3 are already marked full. 0 instructor courses, and 1 no courses are currently scheduled for January, but there will be. And then February, there's already 1 course scheduled, and it is marked as full. And other than that, I don't know much of anything. The trauma funding that ENA was on the Hill advocating for is still kind of sitting out there as far as I know. I know TCAA has also been doing some lobbying on the Hill for federal trauma grants and trauma funding, so we'll see where that goes.
Okay.
Thank you.
Any questions for Sally? Okay. The 10th item on the agenda, pediatric interfacility transfer guidelines. Do we have anybody here from the pediatric committee that can? Come on, Sally, get back up at the microphone.
So you guys saw, you had the guideline on your agenda, right? Everybody looked at it? Everybody's reluctantly going, yeah, we looked at it. So the only committee that is remaining to endorse this guideline as it is this committee. Our hope is that it will get endorsement from you guys and be able to be presented to GTAC tomorrow as the guideline that the GTAC adopts. And then we hope to hand this guideline out to the RACs and ask the RAC chairs to hand it to their PEDS committees and to all their hospitals who may be in need of a pediatric transfer guideline. The Air Medical Committee met yesterday and made some minor, one substantive change, but only a minor change that I think this committee will be interested in. And that is on page 2.
Sally, could you give the committee just a brief synopsis of the whole guideline?
It's just as well. What it is a guideline that says what kids, it gives you some physiologic, anatomic, and other criteria for transfer, patients that should be considered for transfer to a higher level of care or pediatric facility, both trauma and non-trauma. And one of the things that it says is that acutely injured kids can be safely managed in level 3 and 4 centers in some situations, but when they're critically ill and in need of a higher level of care that exceeds the care they're getting, we had put in the guideline that they should be transferred to a level 1 or level 2 pediatric trauma center. We got some recommendations from Air Medical yesterday for 2 reasons. One, in the Corpus Christi area, Driscoll Children's is not a level 1 or level 2 trauma center. They're a level 3 trauma center and perfectly capable of taking care of a higher level of care for pediatric trauma. And in the El Paso area, where there may be level 1 or level 2 adult centers that have pediatric capabilities, they wouldn't be able to comply with this transfer guideline. So what we did was change that language to read local area, may exceed their local area capability that should be transferred to the most appropriate designated trauma facility with pediatric capability.
So this, the verbiage is consistent with the Orange Book and with respect to pediatric trauma management capabilities?
I hesitate to say that I've read the Orange Book about 500 times, but I don't know exactly what it says. But I'd be surprised if it, does anybody else know whether that meets the criteria? You don't think it meets the criteria? You think they want them to go to a level 1 trauma center, pediatric trauma center?
I believe that's what it says.
Yeah, I
We better
agree.
look. Dr. Esther, you knew that already, didn't you?
I'm just.
Thank you for asking that question.
Edification of the crowd.
And one of the other things that the pediatric committee has committed to do is be the keeper of this guideline. So when it needs to be reviewed and revised, PEDS committee will take on the responsibility for doing that. But I will look at that and see, because that would make a difference. The rest of the information is not changed. There were no recommended changes to the actual criteria. Under the method of transport, we did separate out the definition of the method of transport based on what's in the rule in 157. So it talks about what defines a specialty transport team, and the rest is essentially the same as it was. The last area of the guideline, which talks about what transport method should be used based on the patient's stability or their risk for deterioration. Under stable with high risk of deterioration or unstable, there was a 6-line, 1-sentence paragraph that's been turned into a list of bullet points. So, and then we did update some new hospitals that are should be on the list of children's hospitals. So, I don't think other than that change with the level 1 to level 2 trauma center, a pediatric trauma center. That's the only substantive change that we made. So,
Okay.
don't know what you want.
So is this on the agenda at the council tomorrow for the
It
council?
is on the agenda for the council tomorrow.
Okay, so what do you need from the committee here?
I would really like a motion and approval from the committee to endorse the guideline to move forward to GTAC.
Okay,
The only issue is, Sally, what we have right now is not really in the same vein as the Orange Book, which states in, I think it's chapter 3, the patient should go to the nearest trauma center for all patients, but then in the pediatric section, to the highest level pediatric trauma center available.
Yeah, we made that argument, and you know, one of the things that it says in the guideline is that we never intended this guideline to interfere with already established referral patterns. Where things are working, they should continue to work. But you know, are the hospitals in El Paso going to send a child out of their community to a level 1 trauma center when that means going to Lubbock or Fort Worth or Dallas or Austin or Houston, when they have the capacity or the capability to take care of that child in their own town? I don't know.
can you, if you're going to say anything other than no, maybe you can come to the microphone.
Wanda said no.
Now you have to come to the mic.
Now you have to come talk, Wanda.
I'll let Wanda. I mean, I know she's. I know she's gonna make a great point.
We had a lot of discussion about this, and we are not going to move. Sorry, I'll try to talk very loud. We are not going to move a level 1 pediatric trauma patient 700 and 800 miles away. That's why we created the system where our level 1 facility, working with the children's hospital that is located on the same campus with them, has an integrated program. We have a very good system. ACS has reviewed it. We are not going to move those level 1 pediatric patients out of El Paso.
Has anyone been reviewed on the Orange Book?
No, because it came out after. But their survey was, when was your survey?
June
So
2014.
Yeah,
June 2014.
and the Orange Book started in July.
Right. Was there any recommendation, though, from the surveyors?
No. I mean, it's just not El Paso, it's Corpus Christi from what I heard. And, I mean, the verbiage that you have right now, it covers those two areas. And I understand as far as the Orange Book and ACS, since that's what we go by for level 1 and level 2 trauma centers, that the state will say, well, you have to verify first through them, and then we'll designate you as a trauma center. But I mean, in El Paso, it has been working very good. And ACS was actually very happy, and actually they were very surprised on how resourceful the trauma system was to try to accommodate for kids for the reasons that Wanda just explained.
The Orange Book states, Chapter 10, page 8, top of the page, pediatric trauma centers should be used to the fullest extent feasible. However, pediatric resources may be scarce in some communities. In such areas, adult trauma centers of necessity may serve as the pediatric resource for the region and therefore may need to provide care for injured children. So,
And I think that's what our...
Can you make sure that that specific verbiage or that reference is in your document?
Yes.
So that our verification and what we're doing for the state are congruent?
Yes.
Okay, with those, if those stipulations are met, can somebody make a motion?
I make a motion to approve the pediatric interfacility transfer guidelines with the amendments that we stated, as well as from the amendments from the prior committee.
I'll second that.
Second. All in favor?
Aye.
All opposed or abstained? Okay, Carrie. Colin, did you have
In public comment, sure. I can do it now.
I
I just want to.
Actually, we're there now.
Oh, good. I just want to let folks know, I'm pleased to announce that we were able to last month provide 50 scholarship slots for abbreviated injury scoring with the Triple AM in Corpus Christi and Wichita Falls. So folks primarily from level 4s received that education. So it was a
Super.
yes. Thank you.
Okay, we've now moved on to the general public comment. Please come to the microphone and introduce yourself.
Eric Epley, Executive Director at STRAC in San Antonio, Texas. So I would like to bring to the attention of the group, I don't know exactly how to fix this, honestly, which is odd for me. So we have I think I know exactly how to fix it, but I'll let you come to your own conclusions. The registry, the registry is working. We're pleased with that. But the problem we're running into right now is that the funding for EMS and the funding for RACs is based off of the number, partially the formulas that are included are geography, which doesn't change, the 2010 census, which basically doesn't change till 2020. Something else. One of them has trauma death rates and other things, but the main variable, the thing that can actually move, are the number of trauma runs from EMS and the number of trauma runs from hospitals. And we're running into a glitch from 2013, at least from our perspective, and I think several other RACs have had this difficulty. The registry closes on the calendar year. Let's say it's 2013. It stays and remains open for input or modifications, changes for additional 6 months. Anybody should correct me when I say something that's bad. The challenge is that the EPI registry staff accept runs that may not necessarily meet the funding requirement filter, if you will. Basically, I'll talk about it county. County fields can be left open and be accepted by the registry. If I send a record in and it doesn't have certain fields, it will reject it, but it will allow if you don't have county. When they go to review that at regulatory to provide funding, they must have county because they don't know where to allot that run if they don't have the county field. So you have an accepted record from the Department of State Health Services, except it's not an accepted record to the Department of State Health Services who give you money. This resulted in us an $11,000 cut for STRAC. For CETRAC in Houston, it was a $100,000 cut because Houston Fire, Daryl's not your kind of say, oh, okay, so Houston Fire didn't have Harris County, which we all know Houston Fire's in Harris County. But several 100,000 runs, 300,000 or 400,000 runs didn't get counted, and that decreases your variable, right? So this is a pretty big deal. I think if we simply I don't know who decides who the mandatory fields are, but if we just add things that are consistent, because by the way, once regulatory figures out, 18 months later, you can't even go back and put the county name in because the registry's been closed. So it'd be nice if you can go back and fix it, but you can't go fix it. This is a real problem because while I think everybody ostensibly would like to help the data process in America and make it all better, EMS guys are putting these runs in to make sure their county 911 funds, this is a funding, it's a mandate and a requirement for funding. And when they don't get the funding because they didn't put the right field, but the registry accepted it, we're squandering goodwill. So if it's possible for us from the Trauma Systems Committee, I don't even know who decides what mandatory fields have to be in the registry. I don't know if it's legislated. I don't know if the legislature, we have to go to the governor's office to get a field to say, hey, we need a county in every run. But that would be wonderful.
Eric, while you're there, you might mention how it's important to know from year to year how you're doing. Are your runs going up or are your runs going down?
Daryl, you want to?
Yeah, I got it. So when we get the report and it says, hey, Bexar County submitted this many runs, if you look at numbers constantly, I mean, frankly, I have people put green and red arrows up and down because some numbers going up are good. I like the green and red arrow from the historical perspective. So on those reports that the department issues, we really need that historical perspective to say, here was 2012 and here's 2013, because that might trigger you to say, hey, We did 65,000 runs last year, and it's 37,000 this year. That seems weird because we're getting busier, you know? And so I think we need to provide meaningful reports to the RACs and to those providers so they see differences. And that just helps people participate better and encourages people to want to participate.
So what's the specific ask from the Trauma Systems Committee?
I would like that any requirements that regulatory needs from registry records be mandatory fields from the EPI folks to the registry. So it rejects a record. They reject all kinds of records all the time. You can't get them to go in. So when you finally get to go in, you go, woohoo, except it doesn't really count because,
right.
Okay.
So why can't folks use the zip codes? Why doesn't the computer know what county zip codes are?
It comes up. They're talking.
Is that we can send a man to the moon?
I believe there was a comment on EMS about the county fields and about the count, to keep up with the count on a monthly basis. If I turn in 200, I want to make sure that I was accounted for 200 that counts towards the equation. So I don't know if Rob is going to talk about it.
Yeah, just a couple updates here. So under the new NEMSIS 3.3.4 and even on the legacy, the issue that we're running into is a county of incident occurrence, where the actual incident a county is. So in both these systems, it is a required field. It's a national element, it's required by them, but a national element requirement, what a required field means under NEMSIS or NTB means that you can give the right value, our actual county value, or you can give a null value, a not value, as not recorded. That is an acceptable answer to those organizations. And so if you have that value in there as a required field and it comes out as not recorded, that is the issue. It's not counted. It's not part of it. You don't put that county of occurrence in, you got not recorded, they don't know what it is. So that's where the key is come in right now. It's not that people aren't putting in, and a lot of times, a lot of these systems that the vendors build, they just automatically put not recorded if they don't have the information in those fields. So we accept it. Now, NEMSIS has come back, and NTB, you can actually set those, we can set those as a state, as our own fields, as is if we want a mandatory. Mandatory means you have to have a county value in there. So if they put a zip code, the county value automatically gets put into the system. So it's not zip code, it's not zip code related. It automatically picks up any zip code. But if you don't have a zip code, you need to put a county code in. If you don't put a county code in, mandatory means it's not coming to the system.
So
and that has a lot of implications, not from just from a registry point of view. We're now kind of changing the rules, and I want to make sure everybody understands that we're not going to accept any of those records, and that's going to be a lot of records that aren't going to get accepted.
I think that's where the validation reports came in that Irene's trying to share, because if validation reports can be run on the provider side and on the state side, then a lot of the null values that are currently being accepted that in the end don't yield the money because the runs aren't technically counted, those validation reports will help with that. It's an educational thing, but it's also, let's build in a double check the validation reports. So I think that's where we were headed when we discussed it in the registry work group the other day, and that's why Irene is sharing the screenshots with the state, and they were very receptive to trying to figure out how we can do those validation reports. It doesn't help the past, but I think we are looking to the future, both from an educational perspective and building the validation reports perspective, which is what the hospitals use right now.
Okay, we still need to change the value that say required, mandatory. I don't get it. The EMS guys are submitting runs. They're working on all the other things to get the dang run to go in, thinking the reason they're doing it is to keep their funding stream solid from the county 911, whatever funds it is.
And we had this.
The reason they're doing it is to make sure that money goes. And if we have one field that could sink that ship, we need to make that a mandatory field and train them or build their software to do it or whatever it is.
So I'm getting a message from the state that says it's been corrected and the county of occurrence is mandatory for a record to be created. Is that?
No, that's not true. I said it
Okay,
is a
so
required
we'll-
field at this point in time. That is going to
That's
national. We
interesting.
went to national dictionaries, okay, national standards. So national standards said it has to be a required field. I said that if we wanted to make that field mandatory, we could make that change. But that would have to come from GTAC committees and from the work group. We cannot
Okay.
make that change ourselves.
Okay, that sounds like an easy fix.
Who's the governance of the registry? Actually, does anybody know?
That-
I basically, the statutes give the state the ability to collect data through the registry. And DSHS runs that on behalf of the state. So
We
the head of
actually
DSHS would make that decision.
We actually had this very same conversation about the trauma registry, the hospital registry. We thought all 88 data elements were mandatory, and then we came back and discovered there's required and there's mandatory, and there's only 9 actual points that are actually mandatory, that if you don't have one of those 9 things, it'll kick the record out. We were all under the assumption that all of it was mandatory come January 1 of this year. So we're talking about the same thing. And for some reason, we haven't moved ahead with the 88 being mandatory. We stuck with just the 9. Y'all are just talking about one data point, but this is kind of the same discussion on both sides.
So I just got an update to the prior. It said, sorry, I meant 1/1/16. So evidently this is on the state's radar to fix this as of January 1st of this year.
It is required. It's not, but the dictionary does not say it's a mandatory. And what you,
No. This is
the mandatory.
The state, that's
so-
the state's specific intent is to fix this issue.
Right, but I need to know the difference in the word required and mandatory.
Okay,
They sound a lot.
a required field can take a valid value plus a null value, a not value. You have not recorded. A mandatory field, you can't have a null value. There's no not recorders anymore. So if the people don't know what the county of
So the
occurrence
correct
is,
verbiage would be this needs to be mandatory.
yes.
Okay.
So do we need to make a motion?
Well, I don't think we need to make a motion because this is actually the state's
If you
call,
make
not
it
ours.
mandatory, it won't, and you don't fill it in, you won't get counted. It won't save the record. And you want it, exactly.
Brian, I would,
Can you come to the microphone, Mr. Epley?
I would ask that we make this as comprehensive as possible, because I don't want to ask for the county field to be mandatory, and we find that also you have to have eye color, or there's going to be some other, I would say the request should be any fields that the regulatory side needs to be successful and count that as a run for an EMS agency to get their funds shall be mandatory by the registry staff, regardless of national standards or anything else, because this is Texas. And if Texas requires this to pay them, then we need to require it on the front end, or else we're really squandering some goodwill.
How do we figure out what those fields are?
I think someone who counts
So the
fields
state,
on the registry.
the state already knows those funding contingent fields?
Yes.
Okay. All funding contingent fields need, that's our recommendation.
Yes,
Those
sir.
need to be mandatory elements.
Thank you.
Should we make a motion just officially from here, or is it just a recommendation?
I don't think we need, Colin, I don't think we need to make a motion, do we? It's because it's really the state's. All right.
I would also make a recommendation that you guys, everybody knows who the governance process for the data for both EMS and trauma data is. Is there a formal, do we have a charter, do we have something that describes? I know DSHS owns the data. I know they manage the data through a contractor. I know they have legal ability to handle the data. I'm asking, is there a formal governance process? If that's the Trauma Systems Committee, that's fine. I actually love that. But I'm not sure who the governance committee of that data source of that register, those two registries are.
Okay.
And I really think that's part of the bigger problem.
Okay. Lori, did you want to make a motion then? The worst they could say is you don't need to do that.
Yes, but do I have to repeat everything we've said?
You know how Mr.
Yes.
Christopher takes notes.
I make a motion that that all of the funding contingent fields be made mandatory.
Do we have a second?
Shall be made mandatory.
Shall be made
Okay. Do we
mandatory.
have a second?
I second.
Okay. All right. Any discussion? All right. All in favor?
Aye.
All opposed or abstained? Okay. All right. Any other public comment?
I have two more registry questions. One of these I asked in the EMS committee as well. We too were one of those where we had a number of the EMS runs that were not recorded. And so now that we are moving away from the affidavit, which is a wonderful thing because we'll actually have data, we don't have any way to validate that the number of entries in the system are actually correct. So if I am a hospital and I see 400 patients and I have entered 10, so I entered 10. If I am in the EMS service and I had 40,000 runs and I entered 400, what is the validation to that? And I don't expect you to have an answer, but that's an issue I think we're going to have to deal with. The other question, I know we postponed the discussion about the freestanding emergency departments, but as long as we are talking about the registry, the freestanding emergency departments do not have an identifier. And so for those that are completely independent, we don't have a way to identify those in the registry now. And in our community, we have a number of patients that are transferred from our freestanding to our trauma centers. And if they are I'll use the word satellite, where they are that long hallway from the mother hospital, the number that's entered is the mother hospital. But that's not correct. That's not where the patient came from. And so as we are looking at PI in our system, knowing what is really happening in those freestanding emergency departments is a real challenge, and we have no data about that. So I would encourage us to try, as we're working on all of these things, to make sure that that's part of what we grab hold of.
Okay. So I have a note here also from the state that the state will elucidate their position on to the work group on the freestanding EDs at their next meeting.
That's correct. And also, I'm Rose Walker. I'm a part of the EMS and Trauma Registry. One of the things that we are currently in the process of doing is assigning DSH SIDs to the actual freestanding based on the regulatory list that we have for reference purpose only.
So will that be all freestandings or just the freestandings that are associated with?
Based on the regulatory list of the
Okay.
licensed true freestanding.
Let me explain that to you. That is not provider-based.
Correct.
So provider-based satellite EDs are not included on that list.
But they're the one that we want that.
Right, and I understand that, but just when she's saying that they are
Okay.
putting those in, that does not include provider-based.
And we're only putting them in for reference purpose, like she said, when they're transferring. We're not collecting data from freestanding, just for reference purpose.
Okay.
Okay.
If you could come up to the microphone.
So will that be shared with the hospitals? Because we still need to have identifiable numbers for those freestanding that we get transfers from.
It'll be on the entity reference code list. It'll be on the entity reference code list that you go inside of Maven, you run it, and once we add those, it'll populate there. It's
How are we going to know you added them?
When you run the report, it's automatic. As soon as we enter them, you go in there and you search for whomever you're looking for.
Notice that says you have uploaded
That's exactly right.
Oh, we don't have that. You just go in there. Yeah, you can. We can do a webinar. Once we have it in, we can. What's that? Yeah.
If you're going to make a comment, you really have to come to the microphone.
I mean, it's active. Once we add any entity or facility to the registry, and you go in to run your report, you're going to see it there. So if you go put in ABC Hospital, yeah.
Okay, and as I mentioned, there will be a dedicated report basically charged by the GTAC Council Chair to look at this specific issue. I'm not sure if they'll have any discussion this month, but it's certainly high visibility for the council.
I'm Sheila Lopez from Houston, and I just want to reiterate what Wanda said, is that it's good that we want it to be a mandatory field and that it gets kicked back if you don't complete it. But the essential part that we're missing is if we don't have the feedback to that agency so they can figure out what they have submitted, next year you can be in the same place. They're just adding it, making it, if they make it mandatory, they kick it back. If the agency cannot say, I sent you 20 reports and your report says I sent you 20 reports, we're still at a loss. We're still set up for getting where we are today.
I can only speak from the hospital side, but when I submit 60 records and 5 are rejected, the report comes back that says 5 are rejected, 55 were accepted, and then it'll tell you the reason why. Right. So if that field's made, I can only assume, which is, we all know what that means, that the EMS would do the same thing. They would get a report back.
Yeah, what part of us moving to the national standards and to fix the issues around reporting and to help the people who are submitting the data to us, part of the package that we will be pushing out this fall for hospitals and for EMS is a PDF feedback report, which gets emailed back to the submitter. In this report, it will state every element that is either an error, and if there's an error, it'll kick the report out and you won't even put any data in, and it'll tell you what the errors are. So it'll exactly state what element the error is, what line number it is in your thing, and send back that report to you. That is part of the process we're building into the system right now. We understand there's a deficiency in the previous error reports, so we've re-beefed that up. Under NEMSIS, that goes through both the XSD, they're rules-based, plus a schematron, which looks at the validation of the actual values going in. And if any of that does not meet the certification requirements, that record's getting kicked back to you. You're not even going to be able to put it in. The same thing we're doing for the hospitals. So we're building those same processes in. You actually get a report, any errors or any warnings are actually put in the report and sent back to you. So that is a new piece of stuff that will be coming up this fall, but it will only be, will not be for the legacy data. The legacy data is not going to, still can have the old error report, but the new NEMSIS 3.3.4 submissions and the new XML submissions for hospitals will both get that report in there. We've worked very hard on those reports, and I think when you see them, you'll be pleasantly pleased. You'll be actually look at the data and actually be able to fix your systems.
Okay, thank you.
Christine Reeves with Hot Rack. I didn't have a registry thing till right now, so, and then I'll do my other question. I think what Wanda was trying to say is it's not about the validation of the information in the record, it's the total number of records. It has been mentioned at this particular GTAC that not all trauma centers enter all of the appropriate trauma cases. They enter what they have to for designation, and then they don't enter, which is not good. We can't connect all of the trauma patients to each other if that doesn't happen. Granted, that's typically level 4s, usually. EMS is the same way. There are EMS agencies who only, they're supposed to enter all, we know, but they don't. And so her concern, as well as others, is the number they're putting in, not necessarily the information. So that's a separate issue that she knew couldn't get. Did I verbalize that correctly? And then my other question was, I know Sally left, but there was a request that if hospitals had drowning prevention programs to let Lori know. What if the RACs have drowning prevention programs on behalf of the facilities?
I would assume yes.
Okay, just making sure. We have one of those. So I want to send mine somewhere.
Okay. Any other public comment?
Good afternoon. I'm Prakash Patel with the Injury Epidemiology Surveillance Branch with the DSHS. And I think Dr. Drucker, our previous manager, he had provided the draft of the proposed rule revision of Chapter 103. And we were supposed to get informal comments from the committee members and also through the chair. I have not received anything yet, so I'm here to remind if anybody has any feedback. This is again informal feedback. Please forward the comments to me before the closure of 4th September, which is 2 weeks from here. And please provide me the name, what it is about, like in context to, and then agency name, contact information, so in case if we need to reach them back, we can reach them. Again, this is informal, but once we have the process started, based on the comments, we will try to assimilate the document and then forward to the process further in the system. And then once it is finalized, the State Services Council will discuss the rule revision. And then once it is published in the Texas Register, again, it will be available for formal comments for a month. But right now, this is a time for any informal feedback that you have.
Okay. And Mr. Christopher?
I was just going to ask you the title of the rule.
It is Texas Administrative Code, Title 25, Part 1, Chapter 103.
Thank you.
Okay. Any other questions? Okay, thank you.
And I can provide my contact information, so whoever wants to send me that comments, they can send it to my email address.
Okay.
So I'm going to leave my business card.
And that request has already been disseminated to the committee?
Yeah, it was
or the committee chairs?
Previous GTEC meeting. Dr. Drucker, I think, gave it to Jody Klein, who is the chair.
Okay. All right. Very good. Thank you. Any other public comment? All right. Any announcements? Announcements from the committee? All right. So we have basically we have the agenda for tomorrow. We will again stress some of the basically our recommendations for the input into the strategic plan, and probably the most substantive input we will have for the council is with respect to the contingent fields for the registry to be declared mandatory again, so that we don't lose any more RAC funding. And with that, we will declare ourselves adjourned. Thank you.